Well,
Hi, everyone. Okay, we are watching attendees come in. Sorry to interrupt your conversation, Alice and Mila. We were talking before this started. Happy Valentine's Day, everyone.
came
I
dressed
was
for the
wondering whether it'd
occasion.
be, oh yeah, I didn't even think about that. I was wondering whether it'd be like appropriate or inappropriate to schedule this on Valentine's Day. Like maybe people are like out of town or something, or maybe they're, extra at home today. You never know. Okay, let's get started. So today's brown bag is nutrition and diabetes. It's not one size fits all. We were actually just talking about how the shift happened relatively recently in diabetes history. If you're new to DPAC, our mission is to ensure quality of and access to care, medications, and devices for patients living with diabetes, and to educate, inspire, and empower patient advocates as well as lawmakers. So talking to lawmakers and policymakers about the needs of people living with diabetes and helping people with diabetes tell their stories to best communicate that to lawmakers. So we have our two featured speakers today. Alice Thomas is the vice chair of the board at the Diabetes Leadership Council, our sister organization. She is a nutrition consultant for the Department of Obstetrics and Gynecology at St. Joseph's University Medical Center in New Jersey. Her specialty is actually the intersection between diabetes and pregnancy, as well as gestational diabetes. If you remember, we had her on a brown bag last year in June, May or June about diabetes and pregnancy. She has received numerous awards in recognition of her work in diabetes and in pregnancy, and she will be speaking to us today as a nutritionist. Mila Clark is a diabetes patient advocate, a board certified integrative nutrition diabetes health coach, and a author and a self-taught cook who started her food blog, The Hangry Woman, after being diagnosed with diabetes. You might know her on social media as at The Hangry Woman. She has also launched the Glucose Guide community app, an app for people with diabetes to build knowledge around diabetes self-management, and she is currently pursuing her master's degree in applied nutrition. Yay, okay. So I'll get started right away with the questions. So can you each tell me a bit more about your background in nutrition and your background in diabetes, and what do you find interesting about the intersection between the two?
Alice, I'll
Okay,
give
I'll
it to
speak.
you first.
Sure. Well, I'm originally from Nova Scotia, Canada, and I did all my undergraduate work in Nova Scotia, and then I went to Montreal to do my internship there at a place called the Montreal Diet Dispensary, and it was the only one of its kind in the world because it focused on community nutrition and pregnancy. And I learned a lot about nutrition counseling there, the importance of including nutrition with everything that has to be about diabetes. And then when I moved to the US, we didn't have that many, thinking about it, we didn't have that many patients that had diabetes. And I didn't learn about that until a little bit later. And I'll tell you that a little later on. But my exposure to diabetes and thinking about it, it was with my mom. My mother was diagnosed with type 2 diabetes when I was a teenager. And it really disrupted the family because she spent a few days in the hospital. And then when she came home, she was given these diet sheets. So, how do you take the diet sheets and kind of incorporate that into the way that you used to eat? Because my mom was a stay-at-home mom and we had dessert every day and it was sweet. And trying to go from that to something that, and back then it was like saccharin, and incorporating saccharin into baked goods, that was not really good at all. So when I moved to the US, my first job was as an inpatient relief dietitian. And I moved all over the hospital, and my exposure to diabetes really came with working with obstetric unit and also with patients that in the dialysis unit. And I discovered that many of those patients had diabetes, and talking to them about diet, and just seeing the diet fails, it piqued my interest. And then I left that and came back again, working with pregnant women, and discovered that, especially with women with pre-existing diabetes type 1 and type 2, that back in the 1980s, many of the women had poor outcomes. Many of their babies died in utero, or they died very shortly afterwards. And they had, you know, very high infant mortality or morbidity rates. It's much better now than what it was. But that was like my first exposure to diabetes and their intersection. Diabetes and nutrition has always been from ancient times. When you go back and look at the history of it, um, people knew that diabetes, that sugar was in the urine. And when you look at the early history of it, you'll see that people actually tasted the urine. So that's how they found out that it was sweet. We don't do that anymore, thank God. But some of the early diets, they were either low carbohydrate, high carbohydrate. Sometimes they gave them like almost 3 cups of wine a day. Some of them for starvation. And it was horrible. I felt sorry for the people way back then. But it wasn't until probably around the 1970s that the American Diabetes Association said that you individualize the diets, and it has progressed from where it is today. And I'm sure we'll get into that a little later on.
Yeah. And then adding, my 2 cents on top of what Alice just shared, I have lived with type 1 diabetes since 2016. I originally didn't know. I was misdiagnosed with type 2 diabetes at the onset, and it took 4 years to get my type 1 diagnosis. My mother also lived with type 2 diabetes, and so it was something that was definitely a part of my family unit, but it was never something that my mom wanted to talk about with any of us. So we didn't discuss it. If we saw her taking injections, if we saw her carb counting, I now know what all those things are. But before, if we would ask, what are you doing? She would be like, don't worry about it. You don't need to think about it. And then years later, I did need to think about it, which ended up being so interesting. And really my diagnosis and the way that I had to navigate the medical system kind of inspired me to consider really diving deeper into nutrition and having that really good basic understanding of just how the body works and how it processes food, and then what kinds of things that you can do to very easily change those food habits and make them more effective for blood sugar management. And over time, after being a recipe developer and writing recipes that are diabetes friendly for different publications, I decided it was a good time to maybe jump into the world of nutrition in a more scientific way. And so it led me to really decide to get my master's in nutrition. And eventually, Alice and I were talking about the paths, but eventually either becoming an RD or becoming a diabetes care and education specialist. And so I really thought that I just didn't want people to feel the way that I felt walking out of the dietitian's office. I wanted people to know that you can individualize nutrition and you can still eat the foods that you love. You just might have to approach it a little bit differently.
Thank you. Yeah, you both have such a wealth of knowledge about diabetes and nutrition, both from a personal and a professional standpoint. I wanted to ask Alice, you've seen so many patients in a clinical setting and witnessed firsthand how people's bodies differ, even with the same condition. Mila, you also have experience conducting and gathering research in the field, both formally and socially, as an influencer. And can you both speak to the extent to which people's needs differ and how to curate an individualized diet or meal plan, and where do we start?
You can go first.
Great. I think one of the things that I've seen just over time, as I've worked with people as a health coach, the struggle that comes up is I just don't know how to move forward. I know that I'm supposed to take all of these things out of my diet, but I don't really know what a carbohydrate is. I don't really know how much sugar I'm eating a day. I don't know how to measure my food. I've never read a label in my life. And so like sometimes it's like starting at the basic level and really building someone's knowledge and getting them comfortable with the ways to be able to understand that information. I think the other thing too that comes up a lot is that people are told that their cultural foods are off limits. And so they can have, this like real attachment to their culture. And we all know that food brings us together. Food is very familiar. It's so cultural. It's deeply ingrained in you. And to then be told like, well, you can't really have that anymore because of diabetes can be really discouraging. And everyone is so different. Everyone has foods that they love, foods that they don't love, foods that they would just like never touch because it's not on their radar. But then also everybody has different levels of access to food. So some people may live in a community where there's not a grocery store and there isn't a way to even get to a grocery store that's close, or maybe the nearest food options are all fast food, which is affordable, but sometimes not the best choice for being able to balance blood sugars. And so as I've like worked with people on, okay, like, what do you really love? And like, first, let's talk about the things that you really love. Then let's talk about the ways that you eat them. Then let's talk about like what feelings you have around them. What does it do for you? And then really like telling them, take this list of things that you love and things that you don't love and bring it to your dietitian and walk through it and talk. And sometimes that's a really great way to start the conversation, because maybe you walk in and you have no idea of what you want to keep and what you want to adjust and what you want to throw away. But if you can kind of brainstorm and figure out what things you really like, you can work with a professional to tailor it very specifically to you and make sure that it will help with your blood sugar balance.
Thanks for sharing that, because it's so important. Diabetes is such a complex condition or disease because it affects so many areas of the body. It affects the eyes, it affects the heart, it affects the kidneys, it affects the nervous system, it affects the feet. So it's not one of those silo conditions. So the first thing that I want to do as a dietitian is to find out the person's medical history. That is so important. What other conditions besides diabetes do they have? And I was thinking about and the individualization is so important. I want to know some of the things that you mentioned before. The culture is important. Where they live is important. I want to know if they live in a house. Do they live in an elevator? Do they live in a 5-story walk up? Because those things are important. Do they live in a food desert? Do they live in a food swamp? Do they have transportation? You mentioned those things before. And again, in working with pregnant women, I want to know, if they had diabetes, if they had type 1, type 2 diabetes, and think about some of the patients that I had in the past. I had one woman with type 1 that she was post kidney transplant, and she already had one toe amputated. And so she was much different than the woman who had type 2 diabetes, was on a GLP-1, she was obese, and she was on statins. So we would get the really hard cases, and I love those hard cases, but you have to look at the total patient. So when that person comes in to see you, who is that? Who is behind that face that I see? I want to know as much of the patient as possible so that I can empower the patient, give the patient the tools that they need to make the decisions. But all the things that I mentioned are so important so that I am not impeding, but actually influencing and helping that patient.
Yeah, thank you so much. We had a question in the Q&A asking, how do you help people to see food differently when they see this food is good or this food is bad for me? I know you guys both kind of touched on that a little bit just now in your question, but they saying that this view can be an emotional roller coaster. So do you have any tips for that?
I think one of the tips that comes to mind is like I always like to come from a place of abundance rather than deficit. So instead of saying you can't do X, Y, Z, focusing on what you can do and what you can add and like ways that you can balance rather than thinking, okay, well, all of these things are off limits to me, because that changes someone's perspective instantly when they see that like they have all of these options and they see that there are like lots of ways that they're able to adjust. They come at it with a different mindset than if you were to give them a list and say, all these are off limits, figure it out. Here we go. And so I think coming from that place of here's what's already on your plate and what can we add to make it better for you overall, and still give you the satisfaction that you're looking for, still give you tasty food that fits within the bounds of what your preferences are, tends to go a long way, rather than kind of looking at food as a good food or a bad food. And it's hard to make that shift. It doesn't happen overnight for people. It takes a long time to recognize that food itself doesn't have a moral value. And so you really kind of have to approach it with the information rather than the feeling, which again is really hard.
That is so true. Food is personal. And the thing that we have to keep in mind is that you have to eat. You can't go without eating. I mean, there's no such thing as a lettuce, leaf, and water diet. So again, the word empowerment is so important. How to empower the patient to take the guidelines, the recommendations, the principles that we know, and to translate that so that a person feels, yes, I can have this. I'm used to eating rice 3 times a day. I've had patients that ate rice 3 times a day. And after we finished, they could still eat rice 3 times a day. So trying to make as few changes as possible. Sometimes you have to make wholesale changes. And I tell the patient that, you may need to do this. How do you feel about that? So again, it's empowering the patient and trying not to make too many changes at one time. Find out how many changes that person can make. Some people can only make one change and they'll tell me, you know what, I can do one change and that's it. Fine. What do you want to do? These are the things you need to change. Let's prioritize and see what you want to do first. And a lot of times, once they do that, and they're willing to add to it. And then you have some patients that said, I can do all this. And I say, are you sure? And they say, yeah. And then they come back in like 2 weeks or a month. And then it's like, you know what? I couldn't. I said, okay. So don't think of yourself as being a failure. Let's take a look at it again and see what realistically you can do given your lifestyle, your work. Some patients are shift workers, some work at nights. Do they work in the emergency room and type 1? So those are the types of things that we have to take into consideration, very important things, so that we can come up with the best plan for that person.
Thank you so much. What are your opinions on bad diets like paleo, Atkins, keto, intermittent fasting, carb cycling, and all the works? I'm sure there's more that we haven't even heard of either.
There are millions. If you Google diabetic diets, you'll get like a million. I mean, there are credible sources out there like the Centers for Disease Control, American Diabetes Association, the Academy of Nutrition and Dietetics, NIDDK, National Institutes of Diabetes and Digestive and Kidney Diseases. And then there are some, I'll put it this way, incredible, uncredible sources. But let's define what a fad diet is. A fad diet is a diet that short-term that promises quick results, either a quick weight loss or an improvement in your health condition, but it's without scientific evidence. Now, some of the diets that you mentioned before and years ago, they were thought of as fad diets. But if you look at the 2019 consensus report, nutrition report from the American Diabetes Association, and even the 2025 ADA standards of care, some of those diets that we used to consider, like the Atkins, the low carbohydrate, the higher fat diets, there's inconclusive evidence because they have looked at these diets, studied these diets, but they're not saying now that they are bad diets. What they're saying is that if a person is going to follow those particular diets, that they need to work with a dietitian who has knowledge and skills and is a specialist in diabetes so that they can work with that patient. One of the things with those particular diets is that they're very restricting and very restrictive. And a person may get those results at the beginning. They may lose the weight, their blood glucose levels may normalize, but can they stay on that particular meal plan for a long time? And I've also worked with bariatric patients, and I've told them that, you know what, the more time that I have with you to work with you before the surgery, the more success you will have afterwards, because we're going to transition into the way that you will be eating after the surgery. So if I had a patient for like 6 months or 12 months before, they had more success. But if I had a patient whose insurance company said you only have one visit with the dietitian, it's like, okay, they're not going to have success. And then sometimes they would call me maybe a year or two later and ask to see me again because they are what they're saying, failing. They've regained the weight. And, if you go back to, let's say, The Biggest Loser, if you remember that particular program, and it was a lot of people who were overweight and they lost a lot of weight. But when they looked at those, most of the contestants 5 years later had regained the weight, and some of them were even heavier than when they started the program. So again, those restrictive diets, yes, they work, but does the person have the structure around them to continue that? Because again, eating restrictively, it's hard. It's very hard to keep that for a long time.
Yeah, absolutely, Alice. And I love what you said just about having an eating pattern that's sustainable for you. Like if you can't maintain it, then it's useless, even if you get the results that you're looking for on the onset. And it can be really frustrating. Like I know as a patient, like when, I was first diagnosed, when I Googled like what to eat for diabetes, I got inundated with ads. Oh, do Atkins, do keto, do low carb, don't eat more than 30 carbs per day, which like was jarring. And like, yes, it worked. Yes, like eating low carb got my blood sugars balanced, but I felt awful and I didn't have any energy and I didn't feel good every day. I just kind of was going through the motions to just like survive every day. And it brings in this point of frustration when you're like, oh, well, my numbers look great, but I feel terrible. And that also can't be the answer. Like they both kind of have to work in tandem, and you have to feel good about what you're doing to be able to sustain it over time and keep your blood sugars in range.
One of the keys is, are you healthy with doing what you're doing? Because yes, you may have the numbers, you may get to your target numbers, but if you are not healthy, if you're tired all the time, if you're listless, I question if that particular plan is working.
Yeah. And it's interesting too, because like I could go see my doctor. I was in primary care for a really long time before I got referred finally to an endocrinologist. And in primary care, they really just looked at my numbers and they said, oh, your numbers look great. They didn't ask, how are you achieving these numbers? How do you feel? Are you doing okay? It was like, oh, you're losing weight and your A1C is normalized. Cool, you can go. And so I think the approach matters just as much as the result. And if the approach makes you feel terrible, then it's not worth doing. And you have to find something that you can do and sustain for a long time.
Right. And
Yeah.
one of the things that a lot of doctors don't look at, that I'm starting to look at even more so, is malnutrition. And having physicians do vitamin mineral assays to make sure that the patient, yeah, like you said, that the blood glucose levels might be fine, they may be losing weight. But when you start looking at their like vitamin D levels or the vitamin A or the B vitamins, they're so low that we have to take care of that. So, it's the definition of what is healthy. Is it just having normal blood sugars and losing weight, or is it overall making sure that the person is in tip-top shape?
Yeah, that is just on some of what people are asking in the Q&A too. And on that note, I wanted to ask, we know as people with diabetes and people who work with diabetes that carbs are so vilified. You guys already talked about this a little bit, not just for people with diabetes, just across the board, carbs are equals bad. And what do you think or say to someone whose advice is just cut out carbs?
Oh, the carb police. Yeah. Oh, carbohydrates have been vilified for so long. And we need carbs. Carbohydrates are one of the essential nutrients. It's one of the three macronutrients, the other two being proteins and fat. And certain body functions, like our brains need carbohydrates. And if you follow a high fat diet and not giving your brain the carbohydrates, and I've read it and I've actually not experienced it myself. But Amanda, I remember telling you that I worked with somebody, and before they would go on vacation, if they didn't like how their body looked, they would go on a high fat diet. And everybody knew that they were on this particular plan because their whole personality and attitude changed. And it's like, we can't wait until they go on vacation and get back, and then they're eating normally again. And then I read something not too long ago that they're actually finding research that people who are on high fat diets, they do have a personality change. So if your brain needs glucose, trying to give it fat is not going to work. And in pregnancy also, if a woman has been following a high fat diet, we have to change it, maybe even gradually at first if she's been following a keto diet, because we don't know how those ketones are going to affect the fetus. So the minimum amount of carbohydrates in pregnancy is 175 grams. So if you have a woman who's only been eating like 10 or 20 grams of carbohydrates a day, you have to gradually get her. Will we ever get her realistically to that 175? Probably not. But if we can get her eating more carbohydrates, it probably will have a positive effect on the fetus.
It's
Yeah.
really interesting. I didn't know that.
Yeah, absolutely. And it's anytime somebody ever says like, well, just cut carbs and your blood sugars will be fine. I don't think there's anything you can just do to manage diabetes. It's not like just do this and it'll be okay, or just do that and you'll solve what's happening. It's a huge combination of factors. And I think a lot of it comes down to, and like the way that people feel about individual macronutrients comes down to just not having enough education about nutrition. When you think about, like I grew up in the US, I grew up in Texas, and we didn't have nutrition education. I didn't even know what macronutrients were until I was in college and I started like really working out. And then I was like, oh, I'm supposed to balance these things out. And oh, there are these terms that I should know. And so I think a lot of people have some maybe like misguided direction or misguided thoughts about nutrition in general. And so that gives them kind of those barriers that make them feel like, okay, well, I've read and I've heard and I've seen that this one thing just seems really terrible. And so this is the thing that I'm going to focus on not having because everyone is telling me that it's not good for me, rather than working with a professional and working with someone who can really help to educate you on what that balance looks like. it's really interesting even now, like in this time as things are transitioning, and we're seeing like all of these updates in US health, and like the misinformation is so prevalent and it's so heavy and it's so loud that it is really difficult to know what's true. And so I think that's again where people with that expertise can be really helpful in educating patients on, okay, here are the basics. Like, let's start with this first. Do you know what a carb is? Do you know what a carb does? Do you know why you're tracking carbs, and kind of getting back to that base level of understanding so that they can build on that knowledge later to be able to reach their goals and understand why they're doing what they're doing.
Yeah, and on the topic of misinformation, that's actually a perfect segue to our next question, which is let's talk about stigma surrounding the diet and nutrition for people with diabetes. We do have a lot of questions in the chat, but just want to be sensitive to time, so I'm gonna go through our questions first. So have you ever experienced or witnessed people policing the diets of people with diabetes? And have you seen what have you seen regarding the difference between how type 1s and type 2s get treated, even within the diabetes community, like the stigma amongst different types?
I have some personal experience.
We're talking about that.
Yeah, like just being a person who shares recipes online, a lot of times, and I am very purposeful about not saying what type of diabetes I have, because I feel like there is an image or a stigma that surrounds diabetes in general, and people make really big assumptions. And so I usually will just say, I have diabetes and here's what I eat in a day if I'm doing a video like that. And I'll kind of go through like what my meals look like, how I balance and measure them. People will fight in the comments section. Well,
Sure.
you ate a pancake this morning, and like just because you had yogurt with it, it doesn't mean that that's good for you. You have diabetes, like that's gonna, cause you to have all of these horrible comorbidities. And then other people will say, well, no, I have diabetes and I can eat whatever I want and I take insulin and I do this. And so I think that there is a lot of stigma around like what you look like and what you should be allowed to eat. I think that is probably like the best way that I could say it. Because there are people who don't look like me who can share the same exact thing and they don't get the reaction that I get necessarily. I think the other thing that is really interesting when it comes to stigma, and like again, like another personal experience, is just kind of like walking in to see a new specialist. I remember like the very first time I saw an RD, I was actually really excited because I was like, okay, I'm going to get more information. I'm going to be able to ask a lot of these questions. And when we went through the list of, okay, well, what do you eat and what do you like to eat? And I kind of like went through the list of like, well, here are these cultural foods that my family always enjoys. Like I don't get to eat them often, but I do really enjoy them. Here are like some ingredients I prep for myself. And then having the immediate reaction be like, nope, throw that list in the trash. I'm going to give you this list. And it had ingredients and things that like I had never purchased, that I had never recognized, that I was like, I don't even know how to cook this. Like, you're giving me this list of foods that I don't even know if I like. And groceries are expensive. Like I can't try things that I don't know if I'll like. And so just having that immediate reaction, or even more recently, I decided to go on an insulin pump. I'd been doing multiple daily injections since my diagnosis. And I felt like, okay, I think it's time finally to go on a pump. And so I went to go see a diabetes educator who was also an RD. And I said, I'm here to talk about insulin pumps. And she said, nope, I looked at your chart and I don't like where your A1C is. And we're going to talk about that instead of talking about insulin pumps. So what are you eating? And I was like, but that's not the conversation I'm here to have. And so I think, there are a lot of assumptions that happen around what people eat, how they eat it, why they eat it. And especially like when you are living in a larger body, you may get that pressure and those questions a lot more. And you may have to defend yourself more in those situations, which is unfortunate, but it is definitely something that does happen and can happen. And so being prepared for that, I think, is really good, knowing what you want to go in to talk about, knowing how to respond or not respond to people who are making those judgments is super important. And I think it really aligns with like diabetes and mental health and diabetes and just like the way that we care for ourselves. Like if you feel criticized, you're going to feel like, why try? Why do I even attempt? And so I think one, if people have stigmatizing thoughts or comments, like the person with diabetes really doesn't need to hear it. They don't need your opinion. But also being conscious of responding. And, you know, even if somebody comes up to you in person and says, oh, I didn't know people with diabetes could eat that. I didn't know that like you could have that. Knowing what your response is, whether you respond or not, but being able to educate on the stigma and say, well, people with diabetes can generally eat what they want as long as it's not poison or we're allergic to it. But we just approach our diets a little bit differently. And I'm aware of how this fits into my day. And knowing that and knowing how to kind of respond to that criticism can be really helpful in just like getting it off of your heart.
Yeah, I really appreciate how you're not outward about which type of diabetes you have. It's like, it's very much advocating for everyone in the diabetes community and forcing people to question their own biases. Alice, were you going to say something? Sorry.
Yeah, because we were talking about this at the beginning, that I used to be one of those food police, but I've liberated with my many years of experience. One of the most important things is to find out what is the patient's goals. And they are realistic. They're the ones who are living that experience. And if they want an A1C to be 8, who am I to say, no, you got to get it down to 6.5 or 6? So we have to stay within the confines of what is realistic to the patient. In terms of the difference between type 1 and type 2, yes, long ago, there used to be differences. But again, if you look at the 2025 ADA standards of care, you will see that the differences have shrunk. And there's not one particular like, meal plan for people with type 1s and another one for people with type 2s. And that is so important because you don't want to stigmatize anybody. And like I still hear people say, like, you can't eat rice, or why can't you eat rice? Why can't I have an ice cream every once in a while? Thinking about one particular patient who was having quads, and her family just forbid her. She craved a Big Mac, and they said, nope, can't have a Big Mac. You can't have this and that. So she came to see me. She was referred by the perinatologist who was in the same office. And I said, go have your Big Mac, have fun. And if your family has anything to say about it, come see me. Well, I didn't hear from the family. The next time the patient saw me, she had 3 Big Macs one day at a time. So 3 successive days. And after that, she didn't want them anymore. She was fine. And she was able to go back to follow the plan. But I found that the more pressure that you put on people, the more they want it and the more miserable that they become. So,
Yeah.
let her have it. Didn't kill her. And her babies, all 4 of them turned out
Wow. Yay. That's the happy ending.
fine. It was a happy ending. And she was happy with those 3 Big Macs.
Yay. I'm gonna go a little bit quickly because we're coming short on time. But Mila, as someone who lives with diabetes and has a background in nutrition, what can you tell us about the foods that we all roll our eyes at, like eating pizza or eating cereal? Do you have any recommendations regarding some of these more challenging meals?
Yeah, I think again, like it's really individual. Some people can have a slice of pizza and their blood sugars might spike and then coast. Some people like me who literally just had pizza for dinner last night because that's what our daughter wanted for dinner, struggle sometimes with being able to correct and make sure that we're taking an adequate amount of insulin and not underestimating so that we can stay in range. I always like to tell, people that I'm working with, like, consider yourself a little bit of a science experiment. So test and tinker. Like if you're wearing a continuous glucose monitor, like measure out the portion that you're going to eat and look at what your glucose does and kind of figure out where your gaps are and what you can do to fix them. Like we have the technology, we have the ability to understand the trends in our numbers and in our blood sugars. And so if you say love eating oatmeal and you just feel like, okay, well, every time I eat oatmeal, my blood sugar spike really, really high and I can't get a hold of it, I can't really figure it out. Take a look at the deeper details. Like, what's the portion of oatmeal that you're eating? What are you pairing it with? What time are you eating it? If you do take insulin, you take a mealtime insulin, are you bolusing before or after you have that meal? And kind of taking those factors and seeing what's not working for you and figuring out how to transition them into what will work for you, so that you can still enjoy those foods. Because I won't lie, I love pizza. Like I think pizza is such a great food. It's it's got like all of the different elements. It always is good. Like it's easy to reheat later if you need like something really simple. But it can be really challenging on my blood sugars. And so I still don't have the magic answer. Sometimes I nail it and sometimes I don't, but it took a lot of trial and error, like splitting my boluses or doing a really early pre-bolus before the pizza so that I start out lower before I take my first bite. Taking a walk or exercising after I eat to kind of help with being able to bring that glucose down just a little bit. Or knowing, okay, I'm going to have some activity today. And so this is the perfect day for me to be able to increase the carbs that I'm eating. And that's okay. I think too, like our numbers oftentimes feel like a judgment. And so seeing a high blood sugar can just make you feel bad mentally. Like it can make you feel like, okay, well, I didn't do something right. And like now I'm here and now I'm thirsty and having all of these symptoms again, or I'm using more insulin than I normally would. And I always like to say that like those things are still not a moral judgment. Like your number is a number and it's information and it tells you what the next move forward is and what to do. And if it is really bothering you, it's something that you can note and talk to your healthcare provider about later so that you're able to get an insight into the answers that are going to help you most. And again, like it's so hard when you have access to all of that information and when you see it not going the way that you really want it to go, you're kind of like, well, this is my fault. Like it's on me that this isn't working. But look out for those tools and that support system that you have to really help you with understanding what the best ways to move forward are. And not just putting it all on you. Because maybe sometimes it's like, oh, you weren't taking enough basal insulin, or we didn't have your insulin to carb ratio quite right. So you weren't really bolusing for the right amount. Or maybe you just needed more activity. Like there could be so many different answers. And it's really helpful to remember that like one of the things I always like to remember is there are more than 42 things that can throw your blood sugars off at any point in any time. And so it's not just you. There are so many other things going on, and recognizing that taking that information and understanding it can be really helpful to basically like figuring out the puzzle and doing it better the next time.
Yeah, I totally agree. As someone who also lives with diabetes, like, and also in regard to what you said about like doing experiments on yourself, there are some foods that are just so difficult to count for. And I feel like it's important to, like, when you eat something new or something you really like that made your blood sugar go really high or something, like, just to try to view that as much as you can as data and nothing else, like, and not try to be like, oh my God, like, I can't eat this anymore, because you can. There's so many things that have caused my blood sugar to shoot up like over 400, and I now eat them and I barely have any spike because I like them so much, so I make it work. Like whether it means eating slightly less or writing down exactly how many of X thing translates to what kind of spike in my blood sugar. Like you really can make it work for you a little bit more than you think you can. And in regard to that too, I Also, cereal makes my blood sugar go crazy, but I have a hack now where I melt like a protein powder into the milk, but I do it just enough so that it's like not overwhelming flavor. But when I eat it with the protein powder, no more spike. So there's a lot of little hacks that you can do. And if I really don't feel like eating protein powder, I'll just eat it normally and I'll deal with it. But it
Yeah.
helps. Um, so Alice, we know that everybody's body works differently, and many of your patients are actually eating for two. What can you tell us about balancing all of those factors?
But listening to Mila talk, some of those things will work and some will not work in pregnancy because first of all, the levels, the normal levels that we want in pregnancy are lower than they are for the non-pregnant person with diabetes. But one of the most important things with pregnancy is before the pregnancy. And there's something called preconception counseling, and then there's preconception care. Every person that has diabetes, whether it's male or female, should have preconception counseling, whether or not they decide they want to become pregnant or not. Because in the non pregnant population, about 40% of all pregnancies are unplanned. In the diabetes population, it's even higher, it's above 60%. So if a woman goes into her pregnancy, especially those first 3 months, those first 10 critical weeks, and if her A1Cs are high, let's say in the double digits, and we've had women who had A1Cs at the beginning of the pregnancies that were 15, 16, some of them even higher than that, the outcomes can be, not all the time, but can be pretty poor. So what we do is try to get the woman in for preconception care and get her what we would consider tanked up before. Try to get those A1Cs down to at least 6.5 or even 6.0 before the pregnancy. Because if you can get those A1Cs down, and if she has any type of medical problems, then take care of them before the pregnancy. I'm thinking about some of the patients that I've had in the past, one whose blood sugars were out of whack during the whole time that she was pregnant. And by the time she had retinopathy, by the time she delivered, she was legally blind. So those are the types of things. I mean, we had women that, ended up on dialysis. So it's very important to get those things taken care of, I'll put it that way, or at least to have much better outcomes, kind of like before, taking care of anything having to do with the kidneys, um, heart disease, whatever, before that pregnancy, because it's only going to be amplified or could be amplified during the pregnancy. And then, even with pregnancy, if a woman has diabetes and she's experiencing cravings, that's one of the things, 2 o'clock in the morning, she's craving uh, um, an ice cream sundae. What do you do? Do you want that thing? And the body is telling you that it wants the ice cream sundae. And it's difficult. It's really difficult for the woman who does not have diabetes. For the one who does, won't go through certain things. Sometimes if you just eat a little bit of it and then wait 30 minutes, that craving will go away. Things like nausea and vomiting, in about 90% of all pregnancies, especially in the first trimester, most women are going to have that, what we call the morning sickness. So what do you do with that? I mean, women who have type 1s or those who had type 2s and they switch over to insulin, you need that insulin. So what do you do? I mean, there are things like eating small, frequent meals, avoiding things that are have spicy foods, whatever, maybe eating a protein snack before you go to bed, because we find that if blood glucose levels are too low, then that may increase the possibility of having that morning sickness. So there are certain things that we have to look out for in pregnancy than the non-pregnant person with diabetes.
Yeah, that makes sense. Thank you. Last question. Are there any supplements, vitamins, minerals, or other supplements that are especially helpful for people with diabetes or open to general tips? I think someone in the Q&A also asked about vitamin B and vitamin D in particular. So this, to be clear, is not a stand-in for medication, obviously, just to supplement?
Well, a supplement is what it says. It supplements, it's not a replacement, it's not a medication. And in looking at the recent research that came out again in 2025, because I want to make sure that I'm looking at data and research that's recent. For chromium, for turmeric, for cinnamon, those particular studies for those particular nutrients are inconclusive. And I know that many people take the chromium, take the cinnamon, whatever, but when you look at the evidence is inconclusive. Now, if a person is taking metformin, then their healthcare providers should periodically be looking at their vitamin B12 levels. That's very important. And I want to just mention something in pregnancy too, and with herbal medications, even for those who are not pregnant, it's very important that you tell your healthcare provider any medications that you are taking, and also dietary and herbal supplements, because some of them can affect blood glucose levels. And I'm thinking about one patient who was referred to me by a perinatologist. And I happened to ask her, if was she taking any herbals, and she started mentioning that. I said, okay, so the next time you come in, bring a list. She was taking 8 different herbal medications. So, a lot of doctors now are asking not only what types of medications are you taking, but also any type of over-the-counter or dietary or herbal supplements. And it's important that you let your doctor, your healthcare provider know if you are taking any kind of supplements, because again, it can affect your blood glucose levels.
Sorry, Mila, did you have anything to add?
No, nothing to add.
Oh, okay, good.
Alice is the pro, so I knew
Covered
she
all the
would ask that
bases.
question.
Okay, well, that concludes our time. I'm sorry we went a little bit over today. It just means we had a lot to talk about. I know we didn't get to all the questions in the Q&A. Feel free to DM us or comment or email us. This is the QR code to sign up to be a champion, and then you have all of our socials there. So thank you everyone for joining us today. We had a great time on this talk.
Thank you so much.
Thank you.
you.